चेंज करें नहीं ठीक है मैं देख लेता हूँ स्क्रीन कौन कर दी ना भैया कौन है अगर क्रॉस करूँगा मैं देख के करना एक घंटे के उसको निकाल दूँ
reduction of the lumen or minimal. Contrast clears from the lesion very fast. If you do I will show a large residual lumen despite the presence of a dissection, and if you measure the pressure gradient across the dissection has to be less than 20. These are classic statements. If you are subintimal, if you think you are subintimal, be careful what you ask. If you think you need hemodynamic support, use it, and if you think you need when your tabletto is 1.5,
हलचल क्यों नहीं दिख रही कुछ आ ही नहीं रहा तो ऑडियो कैसे क्या आएगा म्यूजिक दिया होगा फिर नहीं वैसे नहीं
if a falling pre-dilatation in the stent does not cause, despite hydration inflation, you have to, I think it's much better than finding a stent not fully expanding, etc., etc. The presence of a dissection is not a contraindication for osteopenia. You need to be more careful, but it's not a contraindication for osteopenia. If you plan to place a stent, do not leave the lesion non-stenting because it is difficult to deliver the stent. Be careful because if you plan to place a stent and you cannot place a stent, it's a different region than placing a stent because you decided not to place. At the end, and you cannot place a stent where you decided to do so, perform
Hello. Hello. I am going to share with you a very interesting case who came to us, an elderly gentleman who was above 80 years of age, and when we did his angiogram, then we saw that his right artery is totally blocked off, which was stented a couple of times earlier, and this time he came with unstable angina, and when we saw the left angiogram, we see that there is a tight blockage in the middle part of the left anterior descending artery. A branch is coming off this lesion, and there is a tight lesion at the ostium of the left main. The circumflex stent is also having some disease, but still acceptable. So then we said, okay, in this kind of situation, he is not a candidate for a bypass surgery. He was turned down from surgeons. So then we decided to go ahead to do this intervention. Now what you see here is that his ostium of the left main is very tight, as you can make out from the picture. Very tight lesion here, and the middle part of the LAD is showing a significant blockage at the bifurcation. Now, how to deal with this problem? There are two ways, of course, of dealing with such kind of very heavily calcified blockages. One is that we do a rotablation, and the other is try to do a balloon dilatation using high pressure balloons. And in this case, we decided that we'll try with the NC balloons. If it doesn't work, then we'll go for ultra high pressure balloons. Now, the first thing is to take a wire, which we took a BMW wire, which went easily, but when we were progressing the wire distally, it was getting stuck in the proximal part. But with some persuasion, we were able to bring the wire down. And after the wire was placed in the artery, we pre-dilated this lesion with a 2 millimeter balloon. As you can see here, the balloon is in place. It gave way, but after that, when we were trying to put the stent, nothing would cross, which means that there is a problem. So at this stage, we put another wire, a buddy wire here, and then we went with a ultra high pressure balloon because the NC balloon was not working. So we took ultra high pressure balloon, which is the open NC balloon, and we went to 30 to 36 atmospheres. Now what happens is that the lesion does give way, and then we can go a little bit deeper into the lesion, which is beyond the diagonal origin, and then we went ahead, did sequential dilatations using this balloon, and could create a passage here. So once the passage was created with the buddy wire and with the balloon, we tried to take a stent, but none of the stents was going. So we again pre-dilated with a 2.5 millimeter balloon with very high pressures, and then we were able to take a 2.0 stent, 2.0 diameter stent with 18 millimeter length, and here we see that the stent is in position. We were able to cross this lesion. Once we placed the stent, we thought then we will post-dilate with a high pressure balloon, and as you can see here, we are opening the mouth of this lesion and putting a second stent, which is a short stent. This is a 2.5 into 12 millimeter stent, which is being overlapped with the first stent, and then the lesion looks good. But this is not enough, so we thought we have to post-dilate because it is a 2 millimeter stent in the mid-LAD, which is not enough. So we went ahead with a 2.5 open NC balloon, which is ultra high pressure balloon, and started dilating the stent. So this time it was easily dilatable, and once this was fully done, then we decided that we will have to treat this proximal part of the ostium of the left main. And here you see that after the initial dilatation, we are using a 8 millimeter stent in the ostium of the left main, and here it is a 3.5 into 8 stent which has been deployed, and after deployment again we saw that the stent is not inflating that well. So we decided to take again a ultra high pressure balloon to inflate the stent, because these are very heavily calcified plaques. And once we took this balloon, which is a 3.5 ultra high pressure, we went inside going up to 30 atmospheres into the left main, and then we were able to achieve a good opening. Now you can see that the opening looks good, but after we have opened this, still we see some haziness here. So we said, okay, we'll go more. So we went up to, you see that we have taken the ultra high pressure balloon again in this calcified ostium of the left main, and we are dilating it further, and once the dilatation was complete, the stent was looking good, the lesion gave way, and then we decided to just take a final shot. This is a final shot, absolutely fully dilated left main, which was heavily calcified at a pressure of 30 to 40 atmospheres, and the mid-LAD also. You can see that the stent is fully dilated, the side branch is doing well, and so we were able to finish this very high risk angioplasty, and especially when you see that the RCA is totally blocked off and the diagonal is also not very big. So we were very conscious of this fact that this patient can deteriorate if we are not able to put the stent here. So that's how we could complete it. So I think in very heavily calcified lesions, very elderly patients, and patients where the other vessels are already blocked off, we have to be very sure. And to be very sure, we must have either a rotablation, or we should use ultra high pressure balloons, and I think open NC is the only option right now which is available in this category. So that's how we are able to treat such kind of very high risk angioplasties in elderly patients. Thank you.
The circumflex disease document. They did this case of with impella. Personally, I don't think it's a must to put impella, because we have the EF of 55. It's a lot of disease. I think we have to
In this era of complex and high-risk angioplasties, calcified lesions, undilatable lesions, are one of the most important subgroup of lesions and patient subsets that we come across. And in order to do a good job and in order to revascularize them efficiently, we need to have multiple tools available to ourselves so that we can treat these difficult patients in the best possible manner and get the best results. It's very regularly that we come across heavily calcified lesions which have to be either rotablated or treated with high pressure balloon dilatations to get the optimal result. And it's well recognized that unless we treat these in the most optimal manner to get the largest lumen, we have a greater chances of stent thrombosis and also restenosis. So it's adverse outcomes. Now in the past, we've had regularly those situations where a lesion, even though looks innocuous, is fibrotic or undilatable, or even after a stent has been implanted after pre-dilatation, the stent doesn't implant any further. These, of course, have been the most difficult subgroup of patients thereafter, because once a stent gets implanted, and though the clear understanding is that never stent a lesion unless it's completely dilated and expanded, it's not uncommon to underdilate a lesion and stent it and then realize that the lesion is not expanding adequately and the stent is underexpanded. This not just predisposes to thrombosis in the immediate term and acute myocardial infarctions, but rapid restenosis as well. So it is actually a boon to have non-compliant balloons for such situations, whether it's a pre-treatment of calcified lesions and dilatable lesions, or for post-treatment after stent implantation. But we must also understand that there are lesions which don't respond to non-compliant balloons, and in fact, it's very important to have ultra-high pressure non-compliant balloons, and that's perhaps one of the greatest additions to our armamentarium in dealing with complex lesions. Just in order to make you understand certain philosophy and physiology around it, I've been very comfortable with high pressure dilatations, which some of the operators aren't. And right through the days of bioresorbable scaffolds, my usual pressure of post-dilatation, even of a thin strut metallic stent, is 18 to 20 atmospheres, and it's regularly that I perform high pressure inflations of 22 to 28 atmospheres. But the ultra high pressure balloons go up to 45 atmospheres. And normally the sound of 45 atmospheres, even sometimes 22 to 28 atmospheres, may worry numerous individuals about the risk of perforation. And the 45 atmospheres almost causes an automatic fear of perforation. But I also want to understand the very important fact that it is not the atmosphere which actually relates to perforation, it's the size of the balloon. For example, a compliant balloon going up to 18 to 20 atmospheres becomes a 3 millimeter compliant balloon becomes 3.5 and 3.6 millimeters. And in an undilatable lesion would dog bone at the edges, which would become 3.7 millimeters, and that's where the perforation happens. If one goes to a non-compliant balloon, even the non-compliant balloon at 22 to 28 atmospheres grows from a 3 to 3.4 millimeters. It may not grow to 3.7, but can grow to 3.35 millimeters. And that's a concern. But consider a 3 millimeter balloon, which at 35 atmospheres only becomes 3.1. Now that balloon hasn't expanded. It will actually exert pressure on the undilatable lesion. It will exert pressure on the undilated stent to expand it, but will not perforate the artery because it hasn't grown in size. So perforations are in relation to the growth in size rather than the pressure applied. So that is the reason why one is very comfortable of going ultra high pressures with a balloon which does not grow and still break those lesions which are unbreakable or undilatable with the usual armamentarium. And that is the reason why we actually feel very comfortable going to 35 to 40 atmospheres with these balloons, which are the ultra high pressure non-compliant balloons like the OPN. Since OPN has come into our armamentarium, it's actually been reflective of a greater degree of comfort in many of such patients. I've had patients from other centers with restenosis in an undilated stent. A stent has been implanted in a lesion which didn't dilate completely. Subsequent to the stent implantation, further non-compliant balloon dilatations were performed, which did not result in opening up of the lesion. A 50% residual stenosis remained inside a stent, and subsequently restenosis occurred within 6 months with troublesome angina. And then they've come to me, and I've treated them with ultra-high pressure balloons at 35 to 40 atmospheres with complete expansion of the stent itself and IVUS demonstration of an underdilated, unexpanded stent with circumferential calcium, which then dilates and expands completely. So I think that the move forwards is to have these tools in our armamentarium when we go on to dealing complex patients. Not just that, even optimization of a stent implantation is very important. What looks visually like a completely dilated and expanded stent on IVUS shows you that you're often undersized and underexpanded. We do tend to use non-compliant balloons for these purposes, but again, ultra-high pressure non-compliant balloons like OPN help us in that very fact that we can actually get complete and uniform expansion in diffusely diseased and calcified vessels with the least risk of perforation. Quite opposite to what we think in our usual daily practice, that high pressures of 35 to 40 atmospheres lead to perforation. In fact, they perhaps lead to less perforation and greater optimization of our results for best short and long-term benefits. Let me demonstrate to you a very good example of a case here. Here's a patient who's actually had an angioplasty, a stent implantation at another center 9 months ago. He had heavily calcified right coronary ostia, in which attempts to place a stent, and after the stent was implanted, attempts to completely dilate the stent had failed. A number of non-compliant balloons had been used, optimally sized, and yet the ostium did not expand completely and left behind a residual 50% stenosis at this huge right coronary artery ostium. The patient went home fine without actually having an acute thrombotic event, but rapidly returned in 6 months' time with intractable angina on effort. And we see here that he's got a 90% stenosis at the RCA ostium in a heavily calcified RCA ostium related to an undilated stent. Here are the IVUS images which demonstrate a completely under-expanded stent and the heavy calcification around the ostium. This was first treated by a cutting balloon. It was subsequently treated by what we call a high-pressure balloon, and finally, it was actually treated by OPN at 45 atmospheres. A 4 millimeter at 45 atmospheres is what was needed to completely expand this. All other strategies had failed in this case. And once the lesion was completely expanded at 45 atmospheres with a 4 millimeter stent, it was then treated by a drug-eluting balloon, and here's the full expansion at 4.5 millimeters, which is seen on the IVUS. Completely expanded stent, completely expanded ostia, the circumferential calcium around the ostium broken. This gave an excellent result, as you can see now. This excellent result is actually preserved even at 6 months later with no recurrence of angina. This is only possible because of these ultra-high pressure balloons, which bail us out of these extremely difficult situations. We need to now understand how to use them to the best possible, in the best possible manner, to give our patients the best possible results in the long and short term. I think it's very important that in complex calcified lesions, high-risk lesions, we have the ability to understand and utilize some of these greatest advancements in science and technology as they're provided to us. Thank you. this era of complex and high-risk angioplasties, calcified lesions, undilatable lesions are one of the most important subgroup of lesions in patient subsets that we come across. And in order to do a good job and in order to revascularize them efficiently, we need to have multiple tools available to ourselves so that we can treat these difficult patients in the best possible manner and get the best results. It's very regularly that we come across heavily calcified lesions which have to be either rotoblated or treated with high pressure balloon dilatations to get the optimal result. And it's well recognized that unless we treat these in the most optimal manner to get the largest lumen, we have a greater chances of stent thrombosis and also restenosis. So it's adverse outcomes. Now in the past, we had regularly those situations where a lesion, even though looks innocuous, is fibrotic or undilatable, or even after a stent has been implanted after pre-dilatation, the stent doesn't implant any further. These, of course, have been the most difficult subgroup of patients thereafter, because once a stent gets implanted, and though the clear understanding is that never stent a lesion unless it's completely dilated and expanded, it's not uncommon to underdilate a lesion and stent it and then realize that the lesion is not expanding adequately and the stent is underexpanded. This not just predisposes to thrombosis in the immediate term and acute myocardial infarctions, but rapid restenosis as well. So it is actually a boon to have non-compliant balloons for such situations, whether it's a pre-treatment of calcified lesions and dilatable lesions, or for post-treatment after stent implantation. But we must also understand that there are lesions which don't respond to non-compliant balloons, and in fact, it's very important to have ultra-high pressure non-compliant balloons, and that's perhaps one of the greatest additions to our armamentarium in dealing with complex lesions. Just in order to make you understand certain philosophy and physiology around it, I've been very comfortable with high pressure dilatations, which some of the operators aren't. And right through the days of bioresorbable scaffolds, my usual pressure of post-dilatation, even of a thin strut metallic stent, is 18 to 20 atmospheres, and it's regularly that I perform high pressure inflations of 22 to 28 atmospheres. But the ultra-high pressure balloons go up to 45 atmospheres. And normally the sound of 45 atmospheres, even sometimes 22 to 28 atmospheres, may worry numerous individuals about the risk of perforation. And the 45 atmospheres almost causes an automatic fear of perforation. But I also want to understand the very important fact that it is not the atmosphere which actually relates to perforation, it's the size of the balloon. For example, a compliant balloon going up to 18 to 20 atmospheres becomes a 3 millimeter compliant balloon becomes 3.5 and 3.6 millimeters. And in an undilatable lesion would dog bone at the edges, which would become 3.7 millimeters. And that's where the perforation happens. If one goes to a non-compliant balloon, even the non-compliant balloon at 22 to 28 atmospheres grows from a 3 to 3.4 millimeters. It may not grow to 3.7, but can grow to 3.35 millimeters. And that's a concern. But consider a 3 millimeter balloon, which at 35 atmospheres only becomes 3.1. And that balloon hasn't expanded. It will actually exert pressure on the undilatable lesion. It will exert pressure on the undilated stent to expand it, but will not perforate the artery because it hasn't grown in size. So perforations are in relation to the growth in size rather than the pressure applied. So that is the reason why one is very comfortable of going ultra high pressures with a balloon which does not grow and still break those lesions which are unbreakable or undilatable with the usual armamentarium. And that is the reason why we actually feel very comfortable going to 35 to 40 atmospheres with these balloons, which are the ultra-high pressure non-compliant balloons like the OPN. Since OPN has come into our armamentarium, it's actually been reflective of a greater degree of comfort in many of such patients.
Studying translating stent design in clinical practice, advantages of 60 micron ultra-thin thickness. Now, first speaker is going to be Professor Patrick Simmons. Please put your hands together for Dr. Patrick Simmons.
Good evening. It's a real pleasure to speak at this late time. We are going to discuss a randomized trial using the ultra-thin struts of the talent trial. As you can see, we had two PI and one co-chairman, no less than Kendra Cole. The background of the study is that the recent meta-analysis showed that ultra-thin struts less than 70
Good evening, everyone. My name is Gurmeet, and I represent Translumina Therapeutics. On behalf of my team, I'd like to extend a warm welcome to all of you. Thanks for staying back despite a very tiring day. We have tried our best to have an academic extravaganza which is waiting for you. I think one of the significant things this symposia represents is that a couple of years back, so many technologies were generally represented by a couple of multinational companies who would come and present this technology. But the changing paradigm in the space of interventional cardiology in India not only just remained a bastion of cardiologists, where you brought all the best practices to India. From an industry perspective, we are trying our best to get the best technologies also here. And this symposia just represents our thoughts, it represents our vision to create a company which has not only best technologies, but the technologies which have very high level of clinical evidence. And this is our first effort. We have started this for the last couple of years. Of having the breakthrough technology symposia in most of the meetings. We started with the NIC in 2017, 18, and this year again we present some of the breakthrough technologies. So I'll not take much time. We have to start soon. So there is a little bit permutation and combination because a lot of parallel symposia are happening. So a couple of chairpersons are going to join us probably another maybe 15 to 20 minutes. And we have just one change in the sequence. Dr. Praveen Chandra, who had a talk 30 minutes later, he has to leave for some urgency, so we are going to start with his talk. So I'd like to invite the chairperson and the speakers on the dais. So can I have Dr. Adnan Kasrati? Professor Adnan, can I have you on the dais, please? Dr. Floram Susli? Dr. Praveen Chandra? Dr. Katrina Case? Dr. Mahesh? Can we also have you on the dais, please? Dr. Ashok Seth and Dr. A.B. Mehta are going to join us probably another maybe 10 to 15 minutes. And now I can also see Dr. Antonio Colombo coming here. So I'll request Dr. Antonio Colombo also to be on the dais. And also Dr. Hens Figula. And that's the foundation for that. So he's, I think, joining us in a moment. Probably, I think he's gone to the restroom. So anyway, so we are going to start with the first presentation. Dr. Praveen Chandra does not need an introduction to the crowd here. He's the Chief of Interventional Cardiology at Medanta Medicity Hospital. And he's one of the first users of most of the technologies launched in India. And we are very happy to announce that Medanta Hospital has now one of the highest experience with the Impella device. And he has already performed significant amount of successful cases with it. I thought it's a good idea that he shows the Indian success with the Impella. So I'll request him to present his case first because he has to immediately go for some urgent meeting. So Dr. Chandra, can I have you here, please? And then a mixture of PLA, and the drugs
Thank you, Gurmeet. We are very thankful to you and the industry also for bringing these new devices to us, because this is helping many patients who were left untreated. And I was discussing with you so many times that we need this device for the last 3-4 years. And now we have it, although there are certain limitations which we will discuss, but certainly for a select number of patients it is very useful. So, in this India Live, which is predominantly on emerging technologies, so I'm going to discuss with you about the use of two technologies, which is Impella, which is being used in Europe and United States for many years now. And we in fact started using Impella about 10 years back, when it was very cheap and it was not approved by FDA at that time. So we did many cases that those years, and then it went off from India, and now it has come back again thanks to our friends from the industry who has brought it here. So what kind of cases we are really looking forward to, because from very simple to highly complex cases are being done by interventional techniques, and I will focus on one such case which is really using these two technologies. So what is Impella? For many of you who may have seen and many of you who have not seen this device, this is basically a pump, a mini pump which goes into the left ventricle, sucks the blood from the ventricle and keeps ejecting it out on a continuous basis. It is a continuous rotor pump, as you can see here. That's how it works. So why it is required? Many patients who have low ejection fraction or have any of these anatomies or physiologies, for example, if somebody has a multi-vessel disease, left main disease, all the vessels are occluded, last remaining vessels sometimes, and those patients who are hemodynamically compromised, low ejection fraction patients, having high LVDP, and patients who are in continuous heart failure, when they need intervention, it becomes very tricky. Why? Because when we treat these patients, they sometimes, or in fact many times, go into the spiral of cardiogenic shock because when the balloon dilate these lesions, they develop ischemia, and when this ischemia is there, they already have compromised ejection fraction, compromised coronary circulation, and then they start dipping down. Despite the fact that we put the stent, many of these patients do not make it. They have compromised flow to the end organs, and then of course end organ damage also starts in these patients, renal failure and all sorts of things. They have lactic acidosis, and these patients did not fare well at all. So the heart recovery is the goal in these patients who are really very sick. So we are targeting these patients where we need some kind of a support, LV support, which can be done in the cath lab. So Impella is one of them. So what it does is it unloads the left ventricle, improves the coronary perfusion continuously at that time, improves end organ perfusion, and sometimes you can even give right side support, and then it leads to early escalation and ambulation of these patients. And we have seen when we use Impella in such high-risk patients, it reduces the blood lactate concentration, it improves the perfusion, and that's how it leads us to improve outcomes in patients who are really very sick. So it provides a treatment option for surgical ineligible patients, high-risk patients who need complete revascularization. They reduce the number of stage procedures, reduce the MACE in these patients, and lead to more complete revascularization. And in addition, it reduces the rates of AKI in these patients. Why? Because the blood pressure doesn't fall when we are doing the intervention in these patients. And this leads to reduced need for dialysis and shorter hospital length of stay because they improve rather fast. Now the improved end organ perfusion is very important in these patients who have already working at a very low ejection fraction, low cardiac output situations. And then if we don't maintain the perfusion, they lead to increase in lactate levels, the perfusion goes down, and these patients deteriorate very badly in the next 24 to 48 hours. Many times you see, you put stents, the vessel is flowing, still the patient doesn't improve. So these are the patients where we really need to help them out. And for example, there could be a patient, there is a patient who has a previous bypass surgery, only the last graft is functioning. And that too is 85%, 90% occluded. Then what happens? EF is low. So if you start treating these patients, when you do the balloon inflation, what happens is that the BP immediately drops dramatically. And if it remains dropped, he has slow flow also at the same time, then the whole hemodynamics changes. You put a stent, still the patient doesn't survive because the hemodynamics is not supported. So, but if these patients are in Impella, then they have a chance of a better outcome, and the hemodynamic stability can be maintained. And many of these patients, as you already know, are not surgical candidates where we want to use this therapy. So the hypotensive episodes during intervention go down by more than 50% if we use Impella in these patients. And it reduces the peri and post-procedural MACE and leads us to help patients get more complete revascularization. You can treat more vessels per patient, and that may lead to better improvement in terms of MACE and better outcomes. So these are the results from studies which were done to show whether LVF or the improvement in outcomes happen or not. It did show that there is a significant improvement which happens pre and post PCI in these patients who are very high risk in terms of their, their anatomical or physiological status. So what happens when we do Impella? Actually, this is what it does. This is the pulsatility of the aortic pressure when we are having this patient on the table, but as soon as we dilate these vessels, what we see is that the pulsatility of the aortic pressure goes down. This is what we see immediately, but these patients, if they are on Impella, then the mean pressure remains up. So the perfusion keeps happening in these very high-risk patients. So let me go through this patient, which is very demonstrative of this technology. And this is a 65-year-old male patient, acute coronary syndrome. And let me tell you, he had a bypass surgery done. He tried this therapy, and this was done in just 6 months back, and both the grafts failed, and he has nothing to back up. All the grafts are failing, and he has come back to us in February. This is the very recent case with recurrent ACS, chest pain, failure, and his ejection fraction is just 25%. So this patient was immediately put, our fellows in the intensive care immediately put this patient rightly on the intra-aortic balloon pump. Noradrenaline was started, and the plan was being made. We discussed with the surgeons. Surgeons took about 48 hours to decide whether they want to do a second redo or not. So finally they decided that they do not want to do a surgery, and they referred back to us. So when this patient was referred back to us, then we started planning this case. And then the planning was that we looked at everything else. We stabilized his heart failure. We looked at all the parameters. IVP was continued, and then we decided that we will do this case on an Impella support with a 3.5 liter. So let me tell you, there are two types of pumps which are available, one with a 2.5 liter flow and the other with a 3.5 liter flow. So when we need more support, we use a 3.5 liter flow. And this was a typical patient who will need a 3.5 liter flow. So the Impella preparation was done using a standard protocol. And once the Impella was ready, we took out the balloon pump, and through the same passage, we put the Impella inside. And when we looked at the arteries, I'll just quickly take you through that. And now, this is the angiogram. This is a post-bypass patient. RCA is 100% occluded, and the left main is very, very tight with a lot of calcification, maybe some thrombus also associated with that. The circ ostium is gone, so you hardly see any flow. Now, will you leave this patient on medical therapy? I don't think he will survive for more than a few weeks or days, etc. So this patient is on balloon pump, and we take this conscious decision that the surgeons have declined, now we have to do something. And this is very heavily calcified artery. Doing a rota is also a tricky situation. So what are the options we have? So we then thought that we will put this patient on a support and then go ahead with all this what we have in the armamentarium. So we said, okay, we will do dilatations, but we have to expand the stent. If we do a bad job, this patient will die on the table or will die in the next 24 hours. So we decided that we will go with ultra high pressure dilatations. And first, of course, this is the 018 wire, which is taken through the left side approach, which is the IBP side. This wire is 018 wire, and on this we take the impella. This is the catheter, which has been positioned, and generally once you position it, immediately it shows on the screen. I'll show you the screen that it is a good position, because this should be in the LV and this should be in the aorta, because it has to suck from here and eject here. So this is the continuous suction started. We look on the screen that everything is okay, and then we start the procedure of intervention in this patient. The plan was to open the left main, the proximal LAD, and the circumflex. So we do some initial dilatations using a 2 millimeter high pressure balloon, and then we started using the ultra high pressure balloons, which is the open NC balloons, to create a passage, otherwise nothing will go inside. And we first did a 2 millimeter dilatation at 45 atmospheres, and then we did a 3 millimeter balloon dilatation at this bifurcation, you can see here, going up to again 45 atmospheres. And at 45 atmospheres, it gave way. Now you can see that it has given way, and we are now trying to do this as a crush stenting. Because the problem is, we cannot finish this case with a single stent, because we can't occlude the circumflex also. So what we do is, we do again a open NC dilatation of the circumflex ostium at 40 atmospheres, create a passage, because nothing will go inside. We tried to put a stent, 2.5 millimeters, didn't pass. Then we took a 2 millimeter stent, which was a 2 into 12 Yukon stent. It actually passed inside. And here you see that after the stent was deployed, we did a second stent, which is a 3 into 18 millimeter stent, which is in the left main into the LAD. And again went very high pressures, post dilatation using again the same 3 millimeter balloon going up to 40 atmospheres to expand the stent. Once that was expanded, we further went ahead with the 3.5 NC balloon going up to again 40 atmospheres. So this was heavily aggressive dilatations, and now what you see is that the artery, the left main is fully done, the proximal LAD is fully done, and there is a good flow in the circumflex, and we don't want to treat the distal part because it is extremely calcified, and doing too much will be too much for this patient. So we want patent arteries, and here you see that left main to LAD is patent. The circumflex is looking all right, the flow is good, all the branches are flowing very nicely, and that time we said, okay, this is enough for this patient, he is doing fine. And what happened during the procedure? How impella helped? So what you see here is, this is the pulsatile flow, and as soon as we inflate the balloons, the flow goes down, and as soon as we deflate, the flow goes up, and during this time, the impella kept the flow going, and the mean pressures were maintained at around 100. So this is what you see here. The mean pressures are showing up all the time. So once this was done, the patient was stable. We immediately took out the impella pump on the table. The pro glides were already put, so we closed the artery, and after that, the patient was shifted to the ICU, and the next day he was transferred to the normal room, and no heart failure. His hemodynamics maintained, and the patient did very well after that. So sometimes we take out the impella on the table, but at times when the patients are not so stable, we keep the impella for the next 24 hours or so, and then take it out the next morning. So that is the usual protocol we follow in such high-risk patients with extreme aneurysms, and we are able to get good results in these patients. So basically, we have to identify the high risk in a particular patient before we go ahead and start doing the procedure. Hemodynamic support should be used preemptively rather than when the patient collapses. If you start using, it won't work, because then it is too late. The patient is already in that spiral of cardiogenic shock, and he needed actually the support before that. So Impella has to be used before you start the procedure, and you have to preempt things in this kind of situation. And out of the pumps generally we use a 3.5 pump, which is absolutely the same thing, but the pump, the flow is 3.5 liters, and it is quite easy to use in most of these situations. And the recovery of these patients is generally quite dramatic and early, and you can mobilize these patients, send them home in the next 2 to 3 days' time. So with this, I will stop here. Thank you very much. If there are any questions, we can have just now. So if there are any quick clarification or any queries?
Very contemporary.
Okay.
Thank you. So we also have Dr. Said now coming and chairing the session. I also would like to invite Dr. Ravinder Rao, who is will be speaking later also in one of the Impella high-risk cases. So there was a little change in the sequence because there was a little confusion with Dr. Figura regarding the timing. So his would be a third talk. So the next talk will be by Dr. Floram Susri, please. Dr. Floram. Dr. Floram is the co-chief of cardiology department in Wisdom. He was trained with Professor Bernie Meyer in Bern and has spent many years in interventional cardiology now. Has set up many technologies in Switzerland. And I think OPNNC is one of the technology which he has established all over the world.
Dear Gurmeet, thank you very much for the kind introduction. It's a great honor for me to be here. It's my 7th time in India, and I'll be speaking about the OPNNC super high pressure balloon. As you can see, the presence of calcium has a heavy impact on the outcomes of PCI, and this is just from an old study, but you can see that once you have the presence of calcium in a vessel, putting a stent there automatically means worse outcomes than if there was no calcium. And why is this? It's because I think it has to do with lesion preparation. As you can see here, you have a calcium part which is marked with red arrows. And if you inflate a semi-compliant balloon, then usually you would expand the soft part of the vessel and not really crack the calcium as you intend to do so. And the biggest fear we have is the presence of a coronary rupture, which is a catastrophic event. Professor Colombo said it today in his state-of-the-art lecture. The presence of a rupture is really a bad thing to happen in the cath lab. But I think, and I believe, and this is really important to recognize, that ruptures happen because of diameter, not because of pressure. And I'll try to convince you with that. And it's very important to realize that sometimes if you have... If you have a patient as on the left side, post-cabbage, post-stents, heavily calcified, as you can't see it here unfortunately, then it's very hard to do this job without using an OPN balloon. So the content of my talk would be to speak about good lesion preparation. I don't like the term aggressive because it's really not something aggressive. It's good to prepare the lesion. Then I'll present shortly the OPNNC balloon. Then why leaving underexpanded stent is a bad thing, how to keep procedure simple, and how to combine, if necessary, open NC with rotablation. Professor Castrati sitting here is one of my big idols. In 1997 he published this meta-analysis, and you can see that only one factor was an independent factor, biological independent factor for bad outcomes. It was diabetes. The rest of it was really mechanical. CTO, in-stent restenosis, long lesions, and small diameter. These are all mechanical factors, and only diabetes was really back then an important factor. And things have not really changed much. Still, stent under expansion remains one of the most important problems why our patients are coming back with a target lesion failure in our cath lab. They are not coming back anymore as they used to come with a stent thrombosis, but they do come back with in-stent restenosis. So because PCI failure is very often mechanical, because good lesion preparation will help achieve good stent expansion, and you know, once achieving a good lumen, this is the maximal lumen the patient will take with him. And this is important. In order to achieve this, I believe that it's important to apply pressure in calcified lesion to gain more diameter. And of course, this needs to be safe. The open NC balloon, many of you know it, many of you have also tried it, is a double-layer balloon which you can really expand calcified lesions to very high pressures without bursting the vessel, because you don't increase the diameter. And why do you don't increase the diameter? It's really probably the only non-compliant balloon, and as you can see from the compliance curves are very flat. So going to very high pressures will not make you increase your diameter and burst the vessel. And if you compare with this, just for illustration, with a semi-compliant balloon on the left side, the Maverick balloon, you see that the curves are completely different. And with high pressure, you probably don't get any more linear growth, but you get an exponential growth of your diameter. And this is how you can burst the vessels. So why does pressure matter, and why is this important to realize? This lady, 40 years old, three-vessel disease, RC was the culprit. I pre-dilated her with a 2.5 balloon at 18 atmospheres, as I usually do, and then in this lady I implanted 2 stents because she got a dissection, so I wanted to get on with the case. As you can see, focus on the proximal part. The stent did not expand in the very proximal part. So I post-dilated with a 25 atmospheres with a 3.5 open balloon. And as you can see, still I was not able to correct the stent under expansion with a good balloon. So I used a good balloon, the open NC, but still could not correct the under expansion. However, I will skip this for time reasons. I then used the same balloon at 45 atmospheres, and you can see that then finally the lesion expanded. And I've been speaking about this with different operators who also have a lot of experience, and Dr. Büttner from Germany, who is a known, very experienced cardiologist in the interventional field, he also believes that somehow, and this is also my experience, that at 40 atmospheres we've somehow reached the biological optimum for calcium to break. I don't know if this is true, maybe we need a study to prove this, but this is from clinical experience. How to deal with underextended stents or scaffolds? I think leaving stents underexpanded whilst the underexpanded is not a good thing to do, and we have to correct this. And with Absorb, we learned the lesson from the hard way. If you left stents or scaffolds underexpanded, then you got bad results. In this case, going up to 35 atmospheres really corrected the case, and this patient also had a very good long-term result. Actually, in our series of 800 patients, the results with Absorb were quite acceptable compared to other centers who were not using open NC. Keeping PCI simple in very bad LVs. This was done in 2003 or 2, I think. This lady, 84 years old, bad LV function, ejection fraction of 20. We discussed with cardiac surgeons, but of course, not even in our country, they would not take this case on. It was too high risk for CABG, so we decided to perform high-risk PCI using IABP back then, because we did not have Impella. Nowadays, I would put this patient on an Impella for sure, but back then, I did not have that. So this was the case. The right is blocked. The circumflex is blocked. The lady was living in a nursing home, and the idea was really to get her out of trouble and bring her back to a nursing home. So how would you do this case in a simple way? Doing a rotablator without hemodynamic support is not an easy task here, because she might become unstable. So it's really simple lesions are required, simple methods are required. So the simple method for me was to use an IABP back then, go femoral, 7 French, 2 Grand Slam wires, and then I used open NC balloons. First I use a normal NC balloon 2.0 at 20 atmospheres to just create some lumen to deploy the open NC balloon. Of course, this balloon, it is a double-layer balloon, so it has a higher profile than a normal NC balloon. That's why you need an extra support wire and you need good catheter support. So then I went with a 2.0 and 2.5 balloon at 40 atmospheres. I had a good angiographic result without dissection. And then I implanted 2 stents, 2 long stents, and post-dilated this with 30 atmospheres with the open NC3.0, and I had a very nice, satisfactory result, and the patient did not become stable. The whole case maybe took about 15 to 20 minutes, because it was very straightforward, and I had the right kit to perform this case. This lady then lived longer than we believed. This was the final result. And she came back after 4 years, had again some chest pain, and I believe she has a restenosis, and re-angioed her. These are angiograms with a 4 French catheter, just for Professor Castrati, who once told me that you can't do good images with 4 French. And as you can see, the result was good. So it paid off to invest some energy and some efforts for this lady with that calcified LED, and this is a good long-term result. I'll show you a final case, because sometimes I encounter into discussions and people say, but how about rotoblator? I think both methods can be added together. They are not really clear opponents. I think you should do that in a very very straightforward way. If you need rotoblator, then use it. If you don't need it, don't use it. So I very often don't need rotoblator and don't use it. This man, 56-year-old, comes directly to the catheter with a STEMI. In the meantime, he had recanalized, wire crossed easily, but then the balloon did not cross. And I was radial. I wanted to apply a GP2B3 inhibitor in this patient, so I did not want to go femoral, use an extra 7 French guide. I said to myself, why don't I do rotablator here, because that will speed the case for me. So I did rotablator, used a 1.5 burr just to create a channel for my balloon. I don't really believe in debulking, and I know this is not a common opinion, but I don't believe that we can debulk lesions. I think we just need a good balloon, and if you cannot cross the good balloon, then you need rotablator to be able to cross it. So then the 3.0 open and C crossed easily. Then I went up to 35 atmospheres with the 3.0 balloon, and here it's very important. I was aiming for a 3.5 stent, so I used a 3.0 balloon at very high pressure. I would have gone even higher if the balloon did not expand. And this is how I prevent vessel rupture, by undersizing the diameter. So this was the result after ballooning. You have a little bit of a dissection, but it's important to recognize after you cross a 3.0 open and C and you have a dissection, you are still safe, because you can always put a stent. If you have a dissection with a normal NC balloon, you still have not cracked maybe the lesion, you cannot deliver the stent, and then you are in a trap. So in this case, I implanted a 3.5 and then a 4.0 at 12 atmospheres, post-dilated with 30 atmospheres, and this was the final result. And again, this patient came back after 1.5 years, and in such patients, I usually do a re-angio if they come back with angina. In this case, he had no restenosis, and the result looked very nice. So if I may conclude, as I said in the beginning, PCI failure is very often mechanical, and a good lesion preparation will help achieve good stent expansion, and this is important. I think if we can give some lumen to the patient, the day he leaves, this is the maximum lumen he will ever have. From that day on, he will have less and less and less lumen. I think in calcified lesion, very often more pressure and not more diameter is needed. If the stent does not expand, don't oversize with your normal non-compliant balloon your diameter, but upsize the pressure by taking a real balloon. And then the open NC balloon is the only balloon which safely allows dilatation at very high pressures without really bursting the vessel. I'm a bit ahead of time, thank you very much, and maybe I can show you the 2 slides about the open India registry, which is a great thing, because I think this is how we can really look into the situation, how open behaves in an Indian population. I think this device is badly needed here, and this would be the objectives and the study hypothesis. Thank you very much for your attention, and if you have any questions, just approach me. Thanks.
Thank you very much. That was truly illustrative of a whole new philosophy about not being scared of, not being scared of pressures, which is intuitive. We're all scared of high pressures, but this is a whole new concept and really a great armamentarium. So we'll discuss that in time. The next talk is by Dr. Adnan Castrati.
Thank you so much, Dr. Saros and Dr. Abhinav, for joining us. This next session is an evening symposium brought to you by Novartis.
Dr. Castrati is Chief of Cardiology at German Heart Center and has done, I think all of you have followed the ESA studies, which comes from German Heart Center. So starting from ESA stereo in 2003, which established that thinner struts are better than thicker struts, to an extent of giving his views on the BVS, He has published on almost all spectrum of interventional cardiology. We are very proud that we have Dr. Kasrati today with us, and I'll now ask him to please deliver his talk.
Thank you very much, Ashok. Thank you very much, Gurmeet, for the nice introduction. I had difficulties in accepting this subject, this topic here, because it goes against my principle, and my principle is don't speak ill of the dead. But I had to do it because there are also some positive data in this direction. So we started with very exciting initial results with BVS, with the absorb stent. We led to know that the vessel becomes larger, that the vasomotion is also restored after some time with BVS, which is not true for metal drug-eluting stents, and most importantly, that BVS or absorb is able to reduce the frequency and the intensity of angina. But it didn't take long to understand that these results were probably the result of small sample sizes. When we had the published results of the absorb 2 trial, so we knew that vasomotion was similar to the Excius stent. It was a randomized study, and that the human loss was greater with absorb than with the Excius stent. That means that the vessel was not getting larger as it was thought previously. Another result, surprising result, was that absorb was not associated with improvement of angina, with improvement of quality of life, and you see here many bars, and all of them show that there is no difference in the quality of life, in the angina, between the absorb stent and the Excius stent. My colleague Salvatore Cassese pulled together all the data from randomized trials, not only those from the company, but also from independent investigator-initiated studies, and he was able to put together more than 5,000 patients and perform meta-analysis for the results up to 2 years. It is interesting to see here that here we are the results for stent thrombosis, here are the results for target lesion failure, which is the overall result, mostly the primary endpoint of the trials. And you see that absorb is getting worse over the time. You see here, it was a hazard ratio of 2.52 after 1 year for stent thrombosis, and it increased to 3.15 after 2 years. It was a 23% increase in the risk of target lesion failure after 1 year, and this excess was increased to 32%. What went wrong with the absorb scaffold? Large scaffold strut thickness was one of the reasons. Scaffold material properties are not appropriate for this. Inappropriate overuse of the scaffold. And also the last reason was performance bars set very high by current metal drug-eluting stents. What about the strut thickness? You see that the absorb is very different from all the current metal drug-eluting stents, with a thickness more than 150 micron, which is much larger than most of the drug-eluting stents, metal drug-eluting stents. It is also to note that the strut thickness is very important. You see here one vessel without strut, and the flow is laminar, and the coagulation cascade is not activated. You see here a thin strut stent, which doesn't compromise that much the laminar flow, and that's why the coagulation cascade is also not much affected. And you see here what happens with the large strut. There is a turbulent flow, and the whole coagulation cascade is activated, and this is also the basis for the stent thrombosis, for the thrombosis of the vessel in these cases. We also know from preclinical studies from the group of Virmani that BVS is more thrombogenous than the other bare metal stents or metal drug-eluting stents. You see also that BVS is less endothelialized, almost none of the struts is endothelialized as compared with the very good endothelialization of the bare metal stents and all of other drug-eluting stents. Another problem with BVS was scaffold discontinuity, which has to do with the material properties, and this was the most frequent cause of stent thrombosis in a series of 36 patients analyzed with OCT. Another reason for that is inappropriate or overuse of scaffold. You have seen many cases, bifurcation, etc., that has been also treated with the scaffold. We know now that bifurcation cases are also a predictive factor of stent thrombosis, scaffold thrombosis from the registry, from the German registry, with an odd ratio of 4.4. Interestingly, we studied 1,000 patients from 2 hospitals in Munich, and we found that women were doing better with the scaffold. We were surprised to see this result, and we looked, all the results are better for women than for men, and we had to analyze the characteristics of the lesions in the women population, and we saw that the complex lesions were less frequent by women than by men. One very recent study is our Absorb-MI study with 260 patients. It was run in different countries, in Denmark, in Germany, in Spain, in Russia, and we saw a very good result concerning the diameter stenosis with BVS as compared with science stent. It was a controlled randomized study. And also the device thrombosis was not higher, even it was numerically lower than with science. Interestingly, there was an interaction with the treatment effect between Absorb and the kind of clinical presentation, with STEMI doing much better than non-STEMI patients. It means that if the plaque is soft, if the vessel is large, it might have good chances for Absorb to have good results. I said that the performance bar set was very high by current metal drug-eluting stents, and you see here that the new generation drug-eluting stents are associated with very low stent thrombosis rate up to 3 years. Now, what about the new generation metallic drug-eluting stents? I have distinguished here 2 products coming from the ESAR project, Yukon Choice PC, biodegradable polymer drug-eluting stents, and the Viva ESAR, or non-polymeric dual drug-eluting stent. Why I am focusing on these 2? Not only because they are part of the ESAR project, but also that Yukon Choice PC is the device with the longest evaluated follow-up in a randomized trials with 10 years. And the Viva ESAR is a unique design device with 5-year follow-up data from a large randomized trials. And you know the discussion between CABG and PCI, it was always said that the CABG is having better results at long term. That's why we need a device that provides very good results at long term. Unique features of the Yukon Choice PC are that it increases drug reservoir capacity due to the microstructural stent surface modification. It enables a low quantity of the polymer, and also it enables excellent performance of polymer-free drug-eluting stents. So some preclinical data, which might be interesting in the sense that inflammation is very low, endothelialization is very high with this kind of stent, is comparable to bare metal stents. ESA Test 4 trial was a trial of 2,600 patients, and you see all the publications, starting with the European Heart Journal 2009 and ending now in Circulation 2019, coming from this trial. These are the primary results up to 1 year. It shows a very similar result to the Science and Cypher stent. At the time, Cypher was also very often used in the practice. And we have now the 10 years results. It was a late-breaking clinical trial at the AHA, and it was published simultaneously on Circulation. Here are the results concerning the primary endpoint, the base at 10 years, and you see no difference at all between science and the Yukon Choice BC, and both of the stents were associated with much better results at 10 years than the Cypher stent. Most importantly, stent thrombosis. It was very low stent thrombosis for the Yukon Choice BC, and if you look at the data, 1.8 numerically is the stent associated with the lowest stent thrombosis rate up to 10 years, although there was no significant result difference between science and the Yukon Choice. The highest rate was seen with the Cypher stent with 3.7% at 10 years. The other device is the Vivo ESAR, or the non-polymeric dual drug-eluting stents. We worked with different drugs, for example, with beta blockers, with statins, and at the end we were more successful with Propofol, not because it is also effective after PTCA, but because Propofol is highly lipophilic and it allows the slowdown of the release kinetics of the sirolimus. Here are results regarding the release kinetics, which is slowed down in a comparable way as a polymer-based drug-eluting stents, and also the results regarding inflammation, regarding endothelialization were excellent with this device. You know that there is also another stent, polymer-free stent, the BioFreedom, but you know also that the BioFreedom was compared to a bare metal stent, not to a current drug-eluting stent in the trial. ESAR Test 5 trial, it gave rise to these publications, European Heart Journal 2009, to Cardiovascular Intervention 2017. It is a large trial with 3,000 patients. The comparison is made between this novel drug-eluting stents and the sirolimus-eluting drug-eluting stents. You have the one-year results showing very similar result between the two devices, and we have also the 5-year results for this stent showing that no difference is between sirolimus and the sirolimus dual drug-eluting stent. Now, more importantly, the stent thrombosis up to 5 years, it is very low, 1.3% with Viva ESAR, or the dual drug-eluting stent. To conclude, metallic drug-eluting stents will be the devices of choice, even in the years ahead. Measures able to reduce polymer load and permanence, or to replace it in a safe and effective way, are key successes, features of the best technology. Best support for a specific drug-eluting stent is provided by long-term evidence from large clinical trials. Thank you very much for your attention.
Thank you, Adnan, for a great perspective on the bioresorbable scaffolds as well as the new gen drug-eluting stents. I would like that the questions be left to the end of this session, and then we can have a discussion. I would now like to invite Antonio Colombo, and as well as welcome him to the India Live. We've been wanting him at the India Live for many years, and it's great to actually have Antonio. And Antonio doesn't need any introduction from the whole audience who's sitting here. He's not just pioneered, he's transformed the understanding about stents and their safety over the last 3 decades, I'd say. So over to you, Antonio, to talk about impact.
Thank you very much, Ashok, for the very kind word, and it's always a pleasure to be here. I decided not to present the data. I will present 3 interesting cases. Maybe in some slides I go fast, they are just showing pictures. This is a 64-year-old gentleman, pretty pathetic, with a history of increased assurance of breath, long-standing type 2 diabetes on insulin. So severely impaired LV function, very low ejection fraction, right ventricle like dilated, a moderate ischemic mitral regurgitation, severe functional tricuspid, calcified left main, trifurcational disease, long segment proximal LAD, heavily calcified as the ostomy is immediate, and CTO of the right and first of 2 margins. So it's maybe it's too late to do anything. This is the coronary angiogram. The left main severe. Everything looks pretty bad. So, we used to do these cases with balloon pump. Nothing. I would not do this case without balloon pump. But now with impeller, makes your life a little bit easier. I mean, we saw Samuel Matt doing a case similar to this today without nothing. It's okay. If everything goes really smooth, but if something gets some slow flow, something can really get into real trouble. So the surgeon, of course, did not want to take care of this patient. The EF is a little bit better. I would say by looking at his echo, he's maybe 25%. But anyway, with that anatomy, placing impeller, it's a good solution. The right was not attempted, and then you do the regular procedure. Nothing to show you except, of course, with that classifications, I don't even think you have to consider not doing rotablation. You do rotablation, pre-dilatation, and then implant the stent. I'll go quickly here just to show the tracing prior to balloon inflation. During balloon inflation, you already saw from the first presentation that the heart does not like this stop of blood flow, which is good, but tells you that is most probably viable. And then you stent, and then you do post-dilatation, and you really get a good result because the lesion is well prepared. The same for the intermediate, the circ is a very small vessel, and this is a 2-day post, maybe it's too early to see a significant improvement. But this is a typical case where you need some kind of support. 2 days impelling intensive care units, 14 days of total hospital stays. This is another case, impeller bridging to high-risk percutaneous procedure, left main PCI and transfemoral TAVR in a young patient. So this is a 46-year-old gentleman who comes with pulmonary edema, falling non-ST elevation, high troponin, diffuse anterolateral ST depression. He had prior chemotherapy treated for Hodgkin lymphoma and two melanoma. So this ECG, diffuse ST depression, LV is compromised. There is a mixed aortic valve disease and moderate mitral regurgitation, cardiac resonance, dilated ventricle, moderate systolic impairment, late gadolinium enhancement, reveals extensive area subendocardial and transmural fibrosis, so not a lot of viable myocardium. The coronaries are not so bad. There are some proximal lesions, but overall in good conditions. I mean, in acceptable conditions. So in view of the ISTS, previous chest wall radiotherapy, severe LV systolic dysfunction, decisions were made to PCI rather than surgery. The target are good surgical target from the surgical point of view. So was done regular angioplasty, pre-dilatation, stent placement with a good final result. So 48 hours post-PCI, for this PCI, I think you can do without support. They are straightforward lesions, good distal target. If you want, you can put balloon pump, but I don't think is necessary. He has this severe arrhythmia requires multiple pharmacological intervention. He has pulmonary congestion. Decision was made in view of the refractory fluid overload, cardiogenic shock and persistent arrhythmia, we decided to place an impeller. So this is a different utilization of this device, not to do high-risk PCI, but to take the patient out of a complication. The chest cleared, he urinated tremendously, responded very well, revealed presence of contractile reserve in the septal, mean aortic valve gradient rose because it improves the LV function. The aortic stenosis became clinically relevant, and the decision was made to proceed with the TVR. We did the standard measurement. Of course, the impeller was removed and underwent a TVR. I skip this valve implantation. This valve is not anymore available. Patient made an excellent recovery and was stepped down from the intensive care. 2 days after TVI was discharged, 10 days later in good condition. So I think this is another application of this device to get the patient out of a problematic situation without giving too much catecholamines and without putting the heart into big strain. Finally, I give another unusual indication for this device to treat no reflow. No reflow is a terrible complication. If it's small no reflow, nothing, no big deal. But if it's a big no reflow, especially on the LAD, it's a real problem. And balloon pump really does not really help much. This is an LAD with diffuse disease, was treated with a shock wave because of calcific. Distally, we had to use rot ablation, and then we had slow flow, which did not improve much with nitride, a little bit of improvement. After stenting, proximally, the distal flow really got really bad. And you see that the vessel is not visible at all. This is a typical no reflow. You go with a selective catheter, you inject distally, and the dye all come back proximally. So this is a standard diagnosis of no reflow. There's not much you can do here. You give nitride, you give epinephrine. If there is improvement, you are lucky, otherwise there's not much. Balloon pump helps a little bit, but does not help. We have seen that by putting impeller, you really have some improvement because you decrease the end-diastolic pressure and you open the microcirculation. So you get real improvement. This is at the time of no reflow. You see that the anterior wall and the apex do not move, so we decided to put a mechanical support. So here, after 4 days of impeller, you see good recovery of the distal flow, and the LV. You see some improvement. Here is right after the appearance of no reflow, and here is after 4 days after removing the impeller. A little bit of improvement, not dramatically, but there is some improvement. So this is another indication for impeller to treat severe no reflow. So I think protected PCI is an evolutionary, not a revolutionary concept. It was born in the midst of change that occur in the new society guidelines that promote appropriate use criteria. The total scientific evidence provides reasonable assurance for safety and effect of the impeller to support in protected PCI, but as I showed you, it's not the only application. You saw two different ways to use this device to improve heart failure and to treat severe no reflow. Thank you for your attention.
Thank you. Thank you, Antonio. That was an excellent demonstration of some real treacherous cases, as we call them. Thank you, Antonio. We'll have the questions at the end. And many of you saw the demonstration of impeller live this morning from ourselves at the Fortis Escorts Heart Institute. In fact, I'd recommend that anyone who wants to do complex high-risk interventions needs to understand and learn how to use Impeller for the right indications in the right patients. So we now go over to Ravinder Singh Rao from Jaipur. He's going to talk to us about reaching new heights of high risk with Impeller support. Ravinder is an extremely talented young interventional cardiologist who's setting some really landmarks in this country after his return from the United States.
Thank you, sir, for those kind words. Good evening, everyone. A lot has been already spoken about Impeller, and the hemodynamics and concept and use of Impeller has already been defined. It's the percutaneous heart pump which unloads the left ventricle, increases the coronary perfusion pressure because it decreases the left ventricular and diastolic pressure. So the coronary perfusion pressure is the difference between the mean arterial pressure and the LV-EDP, and LV-EDP is reflected by the coronary sinus pressure. So I'm not going to go into detail because we already described what is a high-risk PCI. So high-risk PCI basically depends on the coronary artery disease, amount of myocardium which it subtends, the reserve which is present in the ventricle, and the fourth one is expertise of the operator, how easily or how difficult a certain subset of lesion is for him. So I think I'm one of the last speakers between dinner, Sonu Nigam, and all of us. So I'm not going to go into these theoretical details. I'll just share some of our Impeller cases which we have done. 82-year-old male patient, ACS, non-STEMI, diabetic COPD, had a prior CVA, high risk for cabbageous decline, angiographically, ostial left main, proximal LAD, mid LAD, circumflex, and Raymer's disease. So the plan was to do an Impeller-assisted Rhoda PCI approach. We do a pelvic angiogram because remember the Impeller sheath for an Impeller 2.5 is 13 French, for an Impeller CP it is 14 French. And we do 2 pre-closes, 13 French sheath, and we measure the LV-ADP before inserting an Impeller. The other thing is you can do a right heart cath before you put an Impeller, and if the LV-ADP is very low, the Impeller pump is not going to work well because it has to suck blood from the ventricle and pump it to the aorta. So if LV-ADP is very low, you can give an extra bolus of normal saline of almost 200 to 300 ml normal saline. So the Impeller is inserted, LV is crossed with the standard JR or a pigtail catheter in exchange for an 018 wire. And so once the Impeller is, this is the angiogram which you can see the ostial left main, the circumflex, the ramus, and the mid-LAD lesion. The circumflex was wired, and the ostium was cut with a 2.510 flextome. The ramus was stented by 2.528 Zion stent, and this was the left main lesion. So ostial LAD 80 to 90%, mid LAD 100%. The mid LAD lesion was crossed, CTO was crossed with a Gaia 2 wire. It was exchanged for a Rota wire, and a 1.25 burr was used to drill the mid and distal LAD. The burr was upsized to 1.5 mm burr on the ostial LAD. So just imagine doing this case without an Impeller. Once these patients crash and they enter into a spiral, it is very difficult for them to come out. So we would use all these devices, as it was clearly highlighted in the previous talk, preemptively. You want to put these devices before the patient crashes, and this is how the hemodynamics are preserved. So this was a 1.5 burr, which was used for the drilling of the ostial left main and the proximal LAD. Then we did a 2 overlapping stents, 2.530 Zions, all the way at the ostial left main, and dilated with a high pressure balloon using a non-compliant balloon. And the Impeller in this particular patient was removed after 2 hours. Patient was shifted to the ICU. There are 2 ways. One is you can remove in the cath lab. The second one is you can keep the Impeller for a couple of hours if patient had slow flow and the EF was low, and then you can wean him off the Impeller support and remove the Impeller after a couple of hours. And if patient had a cardiogenic shock, then the indications would change. ACS, 77-year-old male patient, severe COPD, EF 30%, viability, not a candidate for CABG. RCA was 100% occluded. Diffuse disease, this is not playing. So again, such type of patients don't have any room for complications. So rather than putting an Impeller once the complication develops, you would like to put them beforehand. And this is a rotablator which was done. This is a slide which has changed. So the impella was already inserted prior to doing a procedure, and a left main bifurcation stenting was done using a 3.548 Zion stent, and final pot. I'm not going to go into detail, and final pot was done. The pot was done, and then a kissing balloon dilatation, and this was the final result. And this patient was discharged home on, again, third day, and we never treated the RCA because he has been remained asymptomatic. This is our heart recovery program. We've done 4 impella and 3 ECMO-assisted PCI, and we have used ECMO for cardiogenic shock in 2 patients. Thank you very much for your kind attention.
Thank you, Ravinder. Again, true indication for impella in high-risk assisted PCI. And really, one can get these patients out of severe dire problems by the use of impella. We now go over to...
Is there a discussion allowed? Or
no, I think that would be at the end. And certainly
okay.
we're going to have discussion at the end, otherwise things could actually go much longer than intended. So we'll keep a small time for discussion. So could we now go on to Dr. Hans Figler, who's going to talk about transcatheter tricuspid valve treatment for severe tricuspid regurgitation, beckoning revolution. And I would like Katrina to introduce Dr. Figler.
It's a pleasure. It's a pleasure to introduce Professor Hannes Figula, who is, I think, one of the most well-known personalities in interventional cardiology and has been so during the last decades. He has been head of the University of Jena until 2015. He's holding a lot of patents and is an important player. And I have to say, I enjoyed working with him together on the development of the tricuspid valve, of the tric valve during the last years.
Well, thank you, Katerina. I wasn't prepared that I get such a beautiful introduction. So it's a great pleasure being here in such a vivid and young audience. I mean, coming from Europe, that's probably very different usually. So I'm going to talk about what we call the tric valve. Tric valve is a device which is being applied for the so-called forgotten valve, which is a tricuspid valve. So these are my disclosures. It's a forgotten valve because nobody in the past took care about these patients who came frequently in our hospital. I mean, those with right heart failure, huge leg edema, extended pulmonary jugular veins, and as you might consider, the mortality of these patients is pretty high. Once those are operated, or once they go into hepatic failure, cardiac cirrhosis, they are usually dismissed by the surgeons, and so the mortality rate is pretty high. So this valve is, as compared to the aortic valve, is huge. It's 5 centimeters in diameter, and it has a very flexible annulus, so it's very difficult to deploy a valve and fix it within this annulus. Sometimes on many of those patients, as I showed you in the picture, come to you with these torrential tricuspid regurgitation, so there is no cooptation of the leaflets anymore, and as you might imagine, it's very difficult to treat those patients with any of the following devices, which is annular modification. You can try to cinch the annulus, but once it has this big, is this size, that becomes impossible. Also, the leaflet apposition with the mitral clip becomes impossible. So there are only 2 options being left. That is cardiac carval valve implantation, what we call heterotopic valve implantation, or autotopic valve implantation to replace the tricuspid valve. And as I mentioned, this is very difficult because there's nothing really to fix this valve. I will now focus on what we call tric valves, this heterotopic valve implantation, which is to put 2 valves into the carval circulation, and so preventing the regurgitant flow into the venous system. So this is the concept. First, we start with the superior vena cava valve implantation, and then the backflow is somehow obstructed into the central venous circulation. And that, of course, reduces the regurgitant flow. So we started with this concept together with my co-worker, Dr. Lauten, in 2008. And at that time we did animal experiments, I will show you in a minute. And then in 2010 we made the first in men. And since then we did a lot of compassionate cases, and now we started with a clinical trial in 2018 and hope to get a CE certification in 2019. So these animal trials were being aimed to show the proof of concept, and at that time we were very anxious that the valves might that a thrombotic obstruction might occur, because this is a low flow area, and so we had to show that this doesn't occur. Actually, it does not, and we never saw it in the human cases. And here you see these animal cadavers, and what we could show that once we ruptured the tricuspid valve and replaced it with caval valves, the cardiac output restored in these animals. So then a bunch of publications followed due to this new concept, and now I will just jump on the latest model of the valve, which comes from the company PNF in Vienna, and this is the vena cava inferior valve. You see the huge device, because usually the cava inferior, superior are extended, and this is a belly shaped here, the superior vena cava valve, which is being in this configuration because that should obstruct the regurgitant flow and is appropriate to the variable anatomy there. So it has a short skirt to prevent hepatic occlusion. So it's deployed, we'll see it in a minute, like a chimney in the right atrium, the inferior vena cava valve. It has a bovine pericardium. This is a nidinol frame. And for the superior vena cava valve, same bovine pericardium, which comes in the latest version. It comes as a dry valve, so you just need to flush it, and then it's ready to go. Two sizes, superior vena cava to address superior vena cava of 20 millimeters and inferior vena cava of 38 and 47 millimeters. So huge valves. So for patient selection, we have, of course, some limitations according to the distension of the vena cava, superior vena cava. So, and of course, we have some clinical indications. So the patient should be in New York Heart 3 or more, and should have a life expectancy. As I showed you, some of those patients are really at the end of their life. And there should absence of any other valve disease which might be treated surgically. So this is usually inclusion criteria for the clinical trial now. I don't want to go into details that, and I just want to show you one of our first patients, which was treated in 2014. She had this huge V wave, and we could eliminate this V wave in the vena cava circulation. You see here it's almost abolished once the valve was in. And she then did very well in the ongoing years, and she is still alive. The valve is still functioning, and you see that the inferior vena cava pressure dropped within 25 months. So it takes a while until the right ventricle remodels. New York Heart is 2, and she developed 6 minutes walk test. I mean, she was almost at bed rest, and now she is ambulance, and also her liver function and synthesis restored. So this was a patient, one of the earliest one, and now I want to move on. For the first Indian patient here, which was treated in Coimbatore in July last year, and this was a patient which also a huge V-wave in the central venous circulation, and you can see here this is a pullback from the right atrium into the inferior vena cava. That the V-wave is abolished, and since then the patient is doing better because the pressure on the inferior vena cava is eliminated. So this is the steps of implantation. It's very simple to deploy. I mean, you just put the belly at the side of where the crossover of the right pulmonary artery behind the superior vena cava. This is some roadmap what we use. As mentioned, the valve is now dry. You just need to flush it. You see here the centrifugal hepatic vein and the superior part of the inferior caval valve is in the right atrium, and here then it's deployed, and it does not obstruct the hepatic veins then. And so again, it's very simple once you know where the right atrium ends. And here you see now there is no flow anymore into inferior vena cava nor in the superior vena cava. And now you see the superior valve here. It's like a cardiac valve in the end. And here's the inferior vena cava valve. You see there is no backflow anymore. So although then overall these compassionate cases which we did before the clinical trial showed that the inferior vena cava pressures dropped, as this is depicted here, as well as the right atrial pressures dropped on the long run. They increase in the first run because the conductance is diminished, and here the cardiac index increases, and as on the clinical complaints decrease, New York Heart 3 to 4, and you see only little of those are in 3 and 4 afterwards. Thanks you very much. And in conclusion, one can say CAVI is a very simple interventional procedure as compared to all the annulus reduction devices, like, let's say, clipping of the tricuspid. It leads, doesn't prevent to deploy the valve. Many of those patients have some leads, pacemaker or defibrillators. Torrential TR can be treated, only little anatomical contraindication, and only moderate after deployment of the valve, and this prevents right ventricle failure, as it sometimes happens when the surgeons replace the valve. Patients have a huge increase in afterload, and then they go in right heart failure and die. And this is prevention because we have this overflow of the right atrium. Thank you very much.
Thank you very much, Dr. Figula, for a truly, truly innovative solution to an extremely difficult problem. Now, the floor is open to questions, and I'm sure there would be questions on any of the talks which have gone by. Please go ahead. So, Dr. Figula, the question is, can it be used for pulmonary hypertension cases?
In the clinical trial, we don't or most of our TR patients are functional TRs, so due to pulmonary hypertension. But of course, we have some limits, so in the clinical trial, we exclude patients above 65 millimeters mercury.
So I have a question while others are thinking about it, is the fact that what happens to the right ventricle and right atrium in the longer term? Now we have a situation where the leaking valve's left. The after effects of the leaking valve have been taken care of to some extent, but what happens to the heart as a whole, the right side of the heart over a period of time?
It's a very important question. Conceptually, it's because we obstruct the backflow in the venous circulation in the head, the regurgitant flow is restricted for the right ventricle. So and on the long run, the right ventricle restores, it remodels, it becomes smaller because because of the obstruction of the regurgitant.
Okay.
That's the concept.
Right, that's the concept.
At the extent in the beginning for higher V wave in the right atrium.
All right. Great. Any other questions? Yes, yes, Dr. Amal Banerjee.
Technically, this is a very fascinating implantation. But my question is, what is the effect of IVC and SVC implantation on the RV implantation, I mean the RV remodeling, and also the pulmonary arterial pressure? That is very much required in fact with the clinical rather translation of this procedure is the most important issue. That we require to know that what is the effect on the RV remodeling and per se its effect on the pulmonary artery pressure.
So effect of
pulmonary artery, there is no effect actually. Once of course, the forward flow is increased, the backward flow is decreased. So, I mean, the pulse pressure in the pulmonary artery is a little bit higher, even when they are in pulmonary hypertension.
Thank you.
And the pulmonary artery that doesn't remodel. What remodels is the right atrium. It becomes bigger in the beginning, but then since the right ventricle improves due to the less volume load, in the long run, even the right atrium pressure decreases.
Thank you.
If I may only add one more thing. I think we are dealing with very sick patients. We all know that patients in end-stage right heart failure do have a short life expectancy and a high risk. So I think it is important that we have a simple and ready-to-use technology. And this is why the trick valve system comes as a pre-mounted dry pericardium valve, which means it comes off the shelf, has to be hydrated, and then can be implanted, which brings the procedural length down to 20 minutes, which I think for a very sick patient is something that is doable. And I think this is very important.
Sure. So now it brings me to the end of the session, but I did want to convey some messages to you. And they're very important messages. And they come from the fact that while some of the talks may sound to you as things that you don't have with you, you may have to graduate into, like the impeller, like the trick valve. What is in your hands at the moment for complex angioplasties in everyone's hand is this ultra-high pressure balloon. And I think all of us need to understand the use of this as we graduate into more and more complex technologies to be used in our patients. And that's why I wanted to convey to you these messages. What happens is that we commonly see these patients, and this is unfair to see such patients, which is done in another center, and what happens is that the lesion is undilatable. And then a stent also gets implanted in this lesion without adequate dilatation. The operator knows that this is not being dilated, and yet goes on to stent implantation, and the stent does get implanted and is underdilated, And further non-compliant balloon inflations up to 24 and 26 atmospheres do not dilate this lesion, and the patient is left with a residual stenosis. Lucky he does not have thrombosis, but he does have restenosis. And he also has another lesion on the other side, which has been left alone. And this patient presents with rest angina in a few months' time. This is not uncommon, and once a week I see such a patient. And that's why the messages are being passed to you, that when he comes to me, he has the stent, under-expanded stent. I was able to just get the IVUS across to be able to IVUS it, and you see that there is circumferential calcification, the lower image shows. Circumferential calcification, it was not going to be expanded by anything else. Options, rotational atherectomy through the stent, which is we call a stent ablation. Options, laser explosion or implosion within the stent, which many of you either have nor have the expertise. But you certainly have the expertise for ultra-high pressure balloon dilatation. And all that it requires is take it, this is, sorry, it is in the previous frame. Here it is. 45 atmospheres is what is needed with an OPN ultra-high pressure balloon of 3 millimeters into 10 to break this lesion. It gives a good result. It's followed, as you can see, the earlier part of the RCA has been untreated. That is looked at. And then NC 3.5 at 28 atmospheres done on the unbreakable, undilated lesion, which has been opened by a OPN non-compliant balloon. And a 4 into 8 millimeter DES is placed proximally in the RCA. And you have these large vessels, which were truly underdone because they were calcified, and you have this result, with areas now looking at 9.6 in the proximal segment and 9.6 at where it was undilated, with the calcium totally broken, and 12.4 MSAs in the proximal segment. This patient also has this, and this is where I want to emphasize certain very important facts. He also has a circumflex lesion. It's likely to be as calcified as the previous one. They run in the same patients, and you do have a circumferential napkin ring calcification, as you can see. Rotor-Burr, 1.5, well done. And then here's a non-compliant balloon at 28 atmospheres, not opening up at all. A 1.75 Burr, and again a non-compliant balloon, and it doesn't open at 28 atmospheres. And take an OPN and 35 atmospheres, and you can see then the right figure, the lesion cracks open, and as it cracks open, the OPN also ruptures, but there is no trauma there. And then as the lesion opened, all you do is stent it with a final result of stent implantation, and you have a huge vessel with an MSA of 8.2 square millimeters, with the circumferential calcification broken. So it's a true armamentarium. Here's another one, and I want to tell you that rotational atherectomy that was mentioned is not a panacea to calcified lesions, and quite often that you would require the two together to be able to achieve such results in extremely heavily calcified lesions. For example, here's the RCA, which you can see has a calcified high-grade stenosis in its mid-segment. We go in with a 1.75 Burr and do it. And by the way, 2 millimeter burrs are not available in this country, though I'd like to have taken up to a 2.25 Burr in this vessel. But here it is, that despite the 1.75 Burr, you have a non-compliant balloon at 29 atmospheres and not opening up the lesion at all. So you're stuck. You haven't got a bigger Burr. You've done what you thought was great, and you can't open up the lesion. And yet what you need to do is put in an OPN balloon at that point. You've already rotablated it. Here is that lesion, breaking at 45 atmospheres, maintained for 40 seconds. So you have these extremely calcified lesions which are circumferential. 45 atmospheres, 40 seconds, and the lesion breaks. And of course, then you put in a stent there, a nice 3.5, it actually dilates, and there it is, perfect result. So what is my take-home message to you? Firstly, these tools should be available in every cath lab. Remember that calcified coronary anatomy is a reality. It catches you unawares. It has caught me unawares regularly. Never actually to do a stent implantation if the lesion has not been prepared well. I'm seeing one case a week, and I want to convey that message. clearly, ultra-high pressure balloon dilatation, the balloons don't grow in size, and therefore they're perhaps even safer than using non-compliant balloons at 28 atmospheres, because at 35 atmospheres, your take-home message as you go home today. Ultra-high pressure balloon is a true useful armamentarium in dealing with many of your stenosis that you normally deal with. You perhaps will transfer it to a routine use instead of a non-compliant balloon in time when you gain the confidence of going up to 35 atmospheres, because that balloon at 35 atmospheres is still smaller than a non-compliant balloon at 25 atmospheres of the same size. Thank you very much for your time.
Thank you, sir, for that great, I think.
So I would like to thank all the speakers and the chairpersons for the time, and especially the audience for staying back despite Sonu Nigam playing the music. So we had better music of health playing here. So thanks again.
इधर से बंद किया ना, बाजू का पूरा हॉल बंद हो गया। पता नहीं अब इसमें क्या मगजमारी क्या सर, इसके लिए उसका लास्ट राइट था वो प्रेजेंट, सब कुछ बंद। आज का दिन का कलम बोल रहा हूँ मैं, रुक जा भाई, इतनी क्यों होती है बंद करके जाने की। बोल रहा हूँ वैसे भी